Alrighty. Well, thank you for joining us and to interview with us.
Absolutely.
So if you could just start with introducing yourself, what your degree is and how many years you've been practicing therapy, and just a little bit of background and how many years you've been practicing, that would be great.
So I'm Kristy Lamb. I am a psychiatrist in Encinitas, California. I am an MD trained in family medicine and psychiatry, and started getting interested in psychotherapy during residency, but my training, formal training, was really in psychopharmacology and meds, but realized how imperative it would be to also have therapy background if I was going to do kind of really more effective work. So started connecting with a provider who does intensive short-term dynamic psychotherapy while I was in residency. And so for 5 years, got supervision from him, and then did core training in ISTDP for 3 years, and have connected with a number of people, and then worked to build a clinic that was really going to create mental health, an environment to look at mental health from the biological perspective and medications, but also do deeper therapy. And so started Bold Health in 2017. And so I've been doing therapy, for I guess a little over a decade now, and have found it to be imperative in my work, and really informs my medication management with patients. And so really couldn't imagine doing psychiatry without having a solid understanding of psychotherapy and psychodynamics.
Awesome. And how long have you been supervising MFT candidates?
So since the inception of Bold Health, we've had psychologists and MFTs in our practice. So since 2017, been doing supervision with trainees.
Awesome. All right, so now I'm just going to jump into the more meaty questions. But so to start, have you found that like social media and reality television are having an effect on your clients and kind of their overall mental health and well-being? What kind of role do you feel how it's impacting, the profession of therapy right now?
Yeah, I mean, I think it's playing a huge role, some good and some bad. So I think that there's the two biggest things that I see are the role of social media at large. For some people who are very anxious and socially avoidant, has been a way where people can connect, where people can find communities that they otherwise might not find in their actual geographic location, and connect with people. The problem with that is that there's also less actual live interaction. And I think that this plays a huge role in mental health and in social anxiety, abilities to deeply connect with other people. There can be very kind of superficial connections, and just even the speed of connection over social media. My husband and I were talking about this just the other day, of like a kid getting in a fight on Friday afternoon with a kid at school has to wait the whole next week until school starts again. Most commonly when I was growing up, it was like you'd brood over it. You might be in the shower and think what you would say to the person, but then by Monday you've processed a lot of it. And then when you actually have the interaction, some of the feelings have already been able to be metabolized and to get clear on how you feel. Now with social media, it's all live action, so that the comments, and there's this kind of barrier to anonymity that comes with the screen that allows people to say things that they would otherwise only be saying to themselves in the shower as they're like, having their fight in the shower. And so I think that it speeds up the process of kind of discharging out the feelings, rather than being able to have time to metabolize them and get really clear about what's going on inside. I think that in other ways of, I've heard of parents talking about their kids that in the past, you might find out on Monday that there was a party and that you weren't invited and have to process those feelings. Now you're seeing it in live time as people are shooting selfies and stuff, that if people are being left out, it's live trauma. And that there's also this footprint of trauma. So it's not just that something happened on the schoolyard, it's being documented and it's being spread. And so huge places where this can be an issue as far as problems. I think that's the patient side. On the therapist side, there's a great capacity for increased access, destigmatization. There's room for increased access. The flip side of that is what there's a great book called The Death of the Expert, so that people who have very little training or no training at all can tout themselves as experts, or can throw up a workshop and have absolutely no clinical training. And so we can get into realms where people who really morally and ethically probably shouldn't be providing mental health workshops are. It can undermine sometimes the trust in care when people who are doing things beyond their scope. And I think that's something that we've really kind of even noticed in our clinic, that a number of people will have been to see other gurus or other types of people, yoga instructors, and not that there isn't a huge role for yoga and meditation and all these things, but sometimes these workshops are going beyond their scope and people are getting traumatized and the provider's not even knowing it, but because they're working outside their scope. Sorry, that was a long-winded answer.
But it brought up another a question further down, which is one of the questions was about video conferencing with the client. And if you practice that on occasion, and what are the challenges that come with practicing, like what are the benefits versus the challenges of practicing over telemedicine?
Absolutely. Yeah. So I definitely do some Skype sessions for patients that I have an established relationship with. And it's usually because of logistics, or if somebody has just had a child and, the child is sick, that kind of thing. I try and make it an exception and not the rule, because there really is a difference of being present with someone in person and in live action. And in the type of therapy that I practice, this type of intimate connection with the therapist is really part of the work. To be seen fully and present without a screen in between brings up a lot of feelings. That so much of the work in therapy is within the transference, within the patient and the therapist actually connecting, and real live feelings coming up in the moment. And the screen creates a bit of a barrier to that. It's not that it's an insurmountable barrier. And for some people who have a ton of trauma and who are very kind of affect phobic, it actually can be a great way to start, where there's this separation that feels a little bit more comfortable. But there's definitely a huge felt sense difference between a live session and a Skype session. I mean, I think that's, in my mind, it's unquestionable. I think everybody has different experiences, but for me, it's unquestionable, not only as a patient, but also as a therapist. It's just a different level of connection.
Awesome. So again, this is great because you keep dropping little seeds that I can just connect to the next question. So on the question of transference, one of the questions that we had was, have you found it challenging to avoid countertransference with your clients? And if you've faced issues of countertransference in your practice, like how have you handled it? Have you dealt with it? Have you been able to maybe transition somebody out of your care because of it? That type of thing.
Yeah. So again, the type of therapy that I practice really works to make sure that the patients are aware of their transference, and that part of my work is learning to really understand my countertransference. And there's different types of countertransference. So there's countertransference of how I feel towards a patient. That is how everyone feels when they interact with this patient. If there's someone who is aggressive towards me and I start to have anger towards them, that's kind of a transference that anybody is going to have. And it's useful information. It says, okay, this patient is doing exactly what they do with everyone in the world. So can we use this therapeutically to say, man, I notice my own heat coming up because, gosh, the way that you're speaking to me is actually pretty abrasive. And can we talk about that? Can we look at what's going on? So it can be very therapeutic and very useful. When my own stuff comes up, I have to clear that out. That's the countertransference that's from my past. And that's stuff that I have to be really aware of. And in my view, actually, that is the difference between good therapists and great therapists. That great therapists do their own work and clear out their own stuff so that they can be clear that what's coming up is about the actual real transference in the room, as opposed to my own stuff. And if my own stuff is coming up, it's not a problem. It's going to come up, but I need to be able to know how to deal with it. It's kind of like a surgeon, cleaning the blade as they're in surgery, if my stuff is coming up, if my scalpel is getting kind of gunky, I need to be able to clean it off and be able to come back to the patient in front of me. And so that in and of itself, I think, is the work of a therapist, the therapist's own personal work. Deliberate practice is a great way to do this, because my blind spots with my own patients will obviously get in the way of the work that we do. And so I have to be aware of those, and they're blind spots. So that means working in my own therapy, but also really doing my own deliberate practice to see where there are spots that I am missing things or avoiding things is important. And so I've never had to transition a patient out, and I think that most of it can all be worked with, but it's important to know where the barriers are, and if things are an issue, knowing our limitations, that if there were something that I wasn't really, that I kept avoiding or I would need to just own the fact that this isn't somebody that I can work really well with, and would need to work on that on my own and be able to refer the patient out. So I'm certainly open to it, but it hasn't been an issue for me.
Awesome. Okay. So on the topic of self-care, how do you effectively self-care? For those of us who are, in our journey and heading into the MFT world, the reality is we're going to see a lot of things that are going to be very emotionally draining for lots of different reasons. How do you keep yourself positive and emotionally fit in a way that makes it so you can be present with your clients?
Yeah. And I think this is that part of the deliberate practice, is really owning where am I and what do I need? And so there's lots of different ways to do this. And I think a little bit of all of the above is useful. So I know for me, me being in a good place means I have to be exercising, getting good sleep, just general self-care stuff, eating well, because the work that we do all day long, while often it's sitting in a chair, is a ton of work of taking on a lot of emotional information. And so being able to make sure that I'm feeling physically healthy and emotionally well in my own place, working on my own relationships, doing my own therapy outside of the room is really helpful. That being said, therapeutically, being able to watch my own videos and be able to regulate my own affect. Sometimes I'll watch videos without any of the words and just see what emotions come up, so that I can allow myself to process whatever feelings are coming in. Being in a group practice has been imperative for me. I absolutely love and need the environment to be able to talk through. Just last Tuesday, I was talking through something that I was just getting stuck on something, and it was a really basic concept. And I was like, oh, this is my own shit. I want to take care of the patient in a certain way. And as soon as somebody pointed out, I was like, yep, that's what's going on. Right. So it's helpful to have an environment where people that you love and trust can support you to say, is this could this be going on, so that you can look in. And so supervision on a regular basis is really helpful. And, when I was working in homeless shelters and in the jail, I had even kind of more, it might be kind of silly rituals, but as I was walking out of clinic, I would kind of I had a supervisor who advised me to do something that actually says I'm leaving this at work, so that there is this separation between the work environment, because I would often take stuff home or, perseverate on people I was worried about. And so being able to have a process to leave work at work, it will always kind of filter in, but trying to create that barrier, I think, is also really important, because when we're taking people home with us, it means there's something going on, that our over caretaking role is coming in, unless there's somebody who really is actually in crisis. There's something else going on that we need to clear out if we're taking it home. So working through that is really helpful.
Awesome. So you brought up the watching your own videos. I think obviously because we work together, I know that we video record as much of our sessions as we can with permission from the clients. Can you talk a little bit about that just for my classmates? Because I don't think that that's common practice in most forms of therapy. And so kind of why it's used in ISTDP and what's the purpose of it and how it benefits the practice for MFTs or any therapist.
Absolutely. Yeah. So I think that therapists have a ton of anxiety over videotaping, and understandably this is an art, and we're going to say stupid things, or we're going to say something that doesn't make sense or flub our words. And so being seen, just like the patient being seen, right, it brings up a lot of feelings. But often we put that on the patient. Well, the patient doesn't want to be seen. Most of the time patients could care less. It's just part of my intake paperwork. They're like, oh, you're working to be a better therapist. That's awesome. Okay, great. And they don't even think about it. And so the bigger issue is internally. Can I tolerate seeing myself? And am I willing to look in at myself and really work to, I'm somebody who's more of a self-attacker. So before videotaping, I would just kind of go into supervision and talk about all the things I screwed up. And some people are more on the narcissistic pole of will only share the stuff, how brilliant they were. And then, right. And so, but then everything gets lost. So videotaping is, in my view, imperative for supervision, that, my supervisors actually wouldn't see me unless I was videotaping, because you're going to have a biased view of what you remember. Our own anxieties come up in sessions. There's so many sessions where I'm like, I think I did a great job. And then I look back at the video and I'm like, oh, I didn't really intervene that much. I don't know what was going on. Right. And so where we are for the day can really alter what we remember from sessions. And so being able to actually have actual data to go back to and look at is so useful for supervision, but then also for self-supervision. So then I can go back and look at a session and figure out what was going on. Where did I get stuck? Or how do we go down into this ditch here? And then if with deliberate practice, some of my supervisors have given me homework. So every time you see the patient sigh, rewind, see what happened, what was bringing up some feeling in them. Or say every time the patient says, I don't know, say, would you like to know? Helping me find my voice, find my strength. And so there's lots of great things we can do with video supervision. And to be honest, I think, I don't want to say something too strong, but I think it's imperative. I think it's imperative to become a highly skilled therapist.
Awesome. Do you have time for one more question? I just want to miss another time. Okay.
Yeah.
So I guess maybe just like a bigger kind of multi-question to wrap things up. Just really talking about just the future of the profession, and where do you see, if thinking about all the MFTs that you have kind of supervised, and what is your biggest advice in terms of like them preparing for licensure, like collecting their hours, and really just dealing overall with the anxieties that come with being a new clinician?
Yeah. So I think my biggest advice is do your own work. If you aren't in therapy, get therapy. Even if you don't have any major crises going on or depression or anxiety, you'll notice that we all actually have anxiety. Being able to have space to process, I think, is really helpful. And so do your own work. And then early on, I think it's really useful to get exposure to lots of different environments, different modalities. But the caveat to that is also figuring out which modalities really resonate with your skill set. I see a lot of new therapists trying out 17 different, doing trainings in tons of different places, or getting training from lots of different therapists. And it can be like you're kind of in a washing machine, and it can be really hard to find your own voice. So getting exposure to a lot of different types of therapy, and then I think it's really helpful to pull on all of those different environments, but to find your modality that really resonates with you, because graduation is like the starting line. That the best therapists are in supervision for the rest of their lives, right? Whether group supervision or self-supervision. And so this is a lifelong learning. And so find something that really excites you, that really resonates with how you see how people operate, so that you can kind of dive in and really hone your craft. I think that it was very comforting to me when I would go into my first sessions and be like, just sitting with somebody and being seen feels good. So like, if I'm just present in the room, I'm not going to hurt anybody, right? There was all this fear of, do no harm and try and be helpful. And that's I think a really calming and useful thing. And it's true, but if you want to be really effective, you're going to have to work really hard to really hone your skill. And I think that a lot of people after graduation don't. And statistically, actually, therapists actually get worse over time. And so acknowledging that and saying, I want to be a lifelong learner, I want to engage in this, and just acknowledging that you will have sessions that you come out of and are like, I don't know what just happened, and that it's okay, and to go get supervision and to feel comfortable sharing. And it's a tough process. I mean, I've shown tape for 10 years and I still get really anxious sharing tape with anyone. And I criticize myself in my head and out loud. And it's a process of desensitization for ourselves as well. But building a community, I think would probably be the final piece of find people in your class, in your community, in the specialty that you like, that become mentors. That the person that I saw for 5 years doing supervision with is still somebody that if I get stuck, I call. And I haven't, worked with him in over 8 years, but having those mentors, having those people that you can trust. This is a really tough. This is not having worked in family medicine, it was really great. You could feel like an expert, right? Somebody comes in and they've got E. coli in their urine, so you know exactly how to treat them. In psychiatry and psychology, we're talking about an N of one. Every human that walks through is an individual that is going to throw something new and different at you. And so we have to be constantly learning, questioning ourselves, looking at our blind spots, and having an environment to do that is important.